morning, everybody. Thank you so much, Mark. It's really a great honor and a pleasure for me to come back here to Israel. This is a really wonderful country, and I feel very connected, as Mark said, through our roots 300 years ago. So thank you, everybody, for being here. As Mark said, this is an interactive, I hope, discussion. You most likely are very familiarized with the Ponseti method, and this is a little bit, kind of refreshing some ideas and mostly, any questions that you might have or comments to make it more interactive. But first, I would like to, if you allow me, just always think about Dr. Ponseti. And as Mark said, for 50 years, he was pretty much ostracized in the orthopedic community. He was from Spain, and you can see him here as a doctor for the army during the Civil War. He used to work with Trueta, and they did the treatment of open fractures with a new concept of debridement and immobilization, no antibiotics, with pretty much the same results that we can have today with frames and antibiotics. Unfortunately, he was in the losing side, so he had to leave Spain because of a personal situation. He went to France and then ended up in Mexico, where he met Dr. Farril, which was the chairman of the orthopedic pediatric department in Mexico City. And interestingly, he had been a fellow with Dr. Steinler, the chairman of the orthopedic department at the University of Iowa, a few years before. And he told Dr. Ponseti, you need to go to Iowa, and opened the door for him. And this is the hospital in 1917 when he was built, and it was torn down about 5 years ago. So Dr. Ponseti came to Iowa in 1941. He did his residency in the department for 3 years. And this is Dr. Ponseti here. This is Dr. Steinler. If you know about the Iowa department and program, it's always been based on the long-term follow-up and outcome research since Dr. Steinler established the program in 1913. And it was when he finished his residency that he evaluated the patients treated by Dr. Steinler by surgery and realized that most patients by the age of 30 had a lot of pain and stiffness and difficult life because of that, and started doing his research. And in 1948, he did his first patient. So next year it will be the 70th anniversary of the first patient treated with the Ponseti method in the world. And as Mark said, for many, many years, he was not taken into consideration. But the principles that he established at the beginning of his career, and everybody will agree that any treatment, it will be to correct all the components of deformity. So you get pain-free foot with good mobility. No calluses, means the weight bearing is normal. And no need for special shoes or inserts. So it's a foot that is very functional with good position. Now, that's the goal of pretty much any treatment. However, you add a few more factors like efficiency, how fast you can do that. If it is effective, means if it works for a variety of pathologies, not just idiopathic club foot, if it can be economical. And I think the most important part is long-lasting effects. And I think that's the key with the Ponseti method. So let's analyze the literature to see how are we doing on this. So he published the paper in 1963, and then we revised and did another paper in 2004. The main difference is that at the beginning of his career, he will stop in about 40 degrees abduction, and he will use the brace for about 2 years, year and a half to 2. And the reason, and I think why the orthopedic community didn't catch up onto the method, I believe, is because at 2 years there's still a 60–70% relapse rate. And he did a lot of relapses, and he did a lot of anterior tendon transfers. So it looked like I think for the community, that was not a very effective treatment. Now, he realized that after a few years, and that is what this paper comes on, is you can get pretty much every case corrected. And I put 2 asterisks here because it used to be 2% back in the days. I don't know. I don't remember the last time I have seen a clubfoot surgery in Iowa, and I've been there for 25 years. So they did a few, maybe in the 40s and 50s or something. You can get 5 casts on average, 95% of our patients for idiopathic clubfoot, and relapses then can be reduced by using the brace until 4 to about 11%. It's never going to be 0 because families are difficult sometimes. But these are the numbers that you have to keep in mind, because this is how effective this method is when you do it properly and correctly, and I think that is the key. Now, these results have been validated, and here I want to remark Mark and John Herzenberg. It was the first paper published in 2002 in which he demonstrated that, yes, in the hands of other people, you can actually get about the same results. And then after that, there's been, and this I just ended up in 2007, there's now another 20 or 30 papers showing that you can get 95 to 100% correction rate with the Ponseti method in children's. So it's very clear that literature now supports the Ponseti method. There's been an attempt to do a clinical trial a couple times. The problem is when you do a clinical trial and you put one patient in the Ponseti and the other one in whatever other method, after a while it's illegal. I mean, it's just ethically impossible to continue considering that you should be doing that. And that's the reason why there's no high-level, level 1 clinical trials with the method, because anything else doesn't work. And how fast you can go. In this paper, what we did is, given the situation in Iowa, many people coming from other states, they have to be in Iowa for 2 or 3 weeks, so trying to reduce the time. So here, what we do now is to do the casting every 4 days. So we do Monday, Friday, Wednesday, Monday, Friday. Now you have to have clinic Monday, Wednesday, and Friday to do that, and a volume for that. So you don't have that volume, then doing once a week is okay. But if you have volume and the patients have to go a little faster, you can do every 4 days, and there was no difference, and you can reduce the time up to the tenotomy to about 16 days. And that happened in 98% of the patients. So that is also telling you that clubfoot is not that difficult and not that stiff in most of the cases when you do proper casting technique, and I think that is the key. How efficient? Well, it can be used in other pathologies. You can maybe have seen this foot or similar. We call it complex clubfoot. It's usually a result of casting technique issues. And even in these cases that before it was called resistant clubfoot and undergone surgery, in 2005 we published this paper showing that you can actually turn around these patients and get the feet corrected in the majority of them with an average of 4 or 5 casts, and very few of them require surgery, and we will talk about that later today. This is a paper now. There's been a few more on the use of the method in neglected club feet. This is Alessandro Lorenzo from Brazil, working with Monica in their program. And this was the first attempt to use the method in older children. Here, it was used from 1.2 walking age to 9. Number of casts, it was about 8, I believe, and 75% correction, 8 posterior releases. And I can tell you that now their data is much better than this. It's about 96% correction, which is and now the oldest patient is probably 20 or something in Brazil. So it's actually useful even in the older population, the children. This is a patient of Ana Claudia in Brazil, 16 years old, walking like this. 2 years later, after correction with 6 casts and lengthening. 6 casts, not 20, not 6 months of casting, 6 casts in a 16 years old. And a lengthening of the Achilles tendon. And he has a normal looking foot 2 years later and still not relapsing and with good functionality. It can be used in arthrogryposis. This paper that we published, 16 patients with arthrogryposis, age about 3 months, 95% correction, and then 5 requiring surgery because of relapses. I can tell you that this was also at the beginning. This was in 2005-07, and now the number of surgeries for arthrogryposis is also down to maybe 5 to 10%. This is a patient of Cristina Alves from Portugal. You can see here a very involved case of arthrogryposis. You can see here the casting. It took 10 casts for her to get this defect corrected without surgery, just tenotomy. And this is 8 months later with a foot that still maintains the good correction and relatively good flexibility for arthrogryposis. So it's very effective also in this pathology. You can use it in myelomeningocele. This paper by Matt Dobbs and the group, 16 cases, 96% correction. The problem with myelo is that relapses are very, very high because of the muscular, coordination and so forth. So you have to know that, and you have to be ahead of the game. So 68%, and my experience is about the same. So in myelomeningoceles, as soon as you start seeing relapse, you have to do 2 or 3 casts, stretch it again, and go back to the braces, and then usually a year and a half, then it start coming back, and then you do 2 or 3 casts. You don't wait for a year and a half, because then it will come back, and then it will be much harder to correct. But it's also very effective. This is a patient actually from Monica, 5 years old with myelomeningocele and walking like that. And 5 casts later, she has that correction. And if you look at this here, and you say that this patient had myelomeningocele, and if it was like that a couple months ago, nobody will believe that. But this is what people are getting when you apply the method properly. And also, Monica, stretching the limits of the Ponseti method with Anna A. and Cristina tackle relapses after surgery. And they published this paper in 2009 with 58 patients, 86% correction with just casting and a tenotomy or a lengthening for patients that have 1, 2, or 3 surgeries before. And only 1 foot out of 85 required surgery, and it was because there was a fusion from previous surgery that they did the subtalar release. And relapses are 14%. So very good correction, very good maintenance with the brace. One thing that they learned over the years is that after the age of 4 or 5, doing anterior teeth transfer as part of the treatment, it probably improves the relapse rate. But you can use it also for relapses after surgery. And this is one of Monica's cases, 5 years old, walking like this, 2 surgeries, 8 months and 3 years, and with this amount of scarring and deformity, it looks like very, very stiff. But this is how it looks like. Oh, sorry. Sorry, there's a video that's not running, unfortunately. But you can see here that after about 10 casts, the foot is really stretched in very good position. And unfortunately, the video is not working. I don't know if you have it tomorrow. But the subtalar joint actually moves, which is amazing when you look at this foot like here. So the method is actually very, very powerful in post-surgery relapses, probably better than other options. How economical it is? In the United States, there was a study by Liu Science looking at the codes that the insurance company accumulate for payments and so forth. And what he found is that in a nationwide study from 1996 to 2006, remember 2000 was the year that the Ponseti method started being used in the United States. What they saw is a reduction of clubfoot surgeries in the first year of life from 70, 80% to about 10%. And everything started changing in 2000, 2001, as you can see here, and then after that. So the method in the country has had an effect on the global country, of a country of 300 million people. And so it's not just in one clinic, it's overall in the country. Unfortunately, the numbers are, and we will talk about this later today, although the first year of life is good, after that still there's quite a bit of number of surgeries in the United States. And I think the main key is the long-term results. And I want to call your attention one paper that I think everybody should read, I think this is a must if you want to do club foot, which is this study by Matt Dobbs and the group in St. Louis, which is a 25-year follow-up of patients treated by surgery as babies. So in this study, they evaluated, they did 75 patients between these years with posterior releases in 13, 62 with posterior medial releases. They found 62, and they excluded anybody that has arthrogryposis and so forth. So these are idiopathic club feet. The treatment was the conventional soft tissue releases. I think when people talk about, well, Cincinnati or this and that is how you cut the skin. Because at the end of the day, you are cutting the ligaments, you're cutting the joints, you're cutting the same thing. It's just how you cut the skin. If it is more or less aggressive, that's the only difference to me with the name of the operation. But they did different type of soft tissue releases. So the average was 31 years, and 28. Group 1 is just posterior releases. Before the surgery, they have 4 months of casting, and the soft tissue releases were, around, 7 to 10 months, which is the typical age. Now, what's important is that out of the 45 patients, 39 had another surgery besides the surgery when they were babies. Most of the additional surgeries were in adolescents. So when you see patients and papers that say 2-year follow-up, 5-year follow-up of surgeries, that is not long enough, okay? And then 6 have another extensive release after the first one, as the case that Monica had before. 17 required stapling or calcaneal osteotomies for overcorrection. 9 had an additional soft tissue release, and 3 had a tendon transfer for relapse. 5 have arthrodesis, and when you put all these patients all together, the average number of surgeries per patient was almost 4. So when you do surgery for club foot in a baby, you will be expecting by the time they are mature, they might end up with 3 to 4 more surgeries as an average, okay? When you look at and you compare the patients between the Cooper study, which is 45 patients, 30-year follow-up, and this series, 46 patients, 30-year follow-up, excellent results, only 4% compared to 62, good results, 22%, so this together is 80%, this together is only 26%, and fair and poor result is 75%. So 30 years later, when the kids have surgery as babies and then undergo 2 or 3 or 4 more surgeries, by the age of 30, 75% of the people are going to have very difficult time. And you can see here the moderate or severe arthritis in almost in every joint. And you know that when you have arthritis in one joint in the foot, 10 years later, you are going to have arthritis in another joint or 2 more joints, and you keep going over time. So, and these are only 30 years old patients. When you look at quality of life, and you look at the surgically treated patients here, this is 33, average is 50 for normal, for SF36. You can see that it compares with Parkinson's, hemodialysis, pre-cardiac surgery, chronic heart failure in quality of life. This is not about pain or something. It's just that these people cannot do too much, because if they do too much, then they have a lot of pain, because they have 50 or 60% of them have arthritis. So if they run a mile or they do hiking or something, they pay a very high price. And this was one of the most important findings, I think, in this paper, because we as orthopedic surgeons usually kind of narrow asking questions about the foot, but then you forget about the quality of life of the patients and how much is affected. Now, you can compare that with the Ponseti method, and this is a 50-year follow-up study. We published a paper on this comparing the anterior teeth tendon transfer or not, and this was presented a few years ago at POSNA. And these are the patients that Dr. Ponseti treated in the 50s and 60s with 126. So these are idiopathic patients. We were able to locate 81 of them, and these are the statistics, and 34 couldn't come back because of distance and life. 36 came with 61 club feet for evaluation to the hospital. And briefly, you can see here that between a control population that we use and the cleft feed, most of the functions are about the same. There was a difference in the global score, but which is about 100 is the top with the Labich-Ponseti questionnaire. So 86% is a very good one. And then there was a difference with the appearance of the foot, because sometimes the feet are a little bit smaller than the other side in unilaterals. The calf muscle is a little bit smaller than the other side, and people say, well, it's a little smaller. But functionally, they are all doing really, the majority, they are doing very well. Radiographically, they are usually very well aligned and maintained, very few arthritis. One thing that you will see is a little bit of wedging on the navicular, and I think this could be improved by the casting technique, and we will discuss that this afternoon. And also there were a few patients that have a little bit of flattening of the talus, which I think that can also improve if you do tenotomies pretty much in every patient. And if you use a brace that allows some motion without forcing, like AFOs force the foot up. And I think there's some papers now coming up with more flattening. And the quality of life in patients with clubfoot is 50 is the average, plus minus 3, you can see here, is about normal. So they are not affected by having clubfoot, and they have most of them a normal functional life up to the age of 50. So with this, you can see how the literature now really supports the use of the Ponseti method. I'm preaching here in a course that already is, but for the new generations, I think this is, historically, it's been the last 10, 15 years, and it still is a problem in many other countries, that still there's some resistance to acceptance of the method. And I think the main problem that we see today is that many people say, I do Ponseti, but they don't follow the protocols correctly. And in the United States, we will show you data later, about 50% of orthopedic surgeons are doing surgery after the first year of life. And the number of surgeries in the United States after the first year of life is about unchanged from before Ponseti. So there's still a lot of work needs to be done, and I hope that here in Israel, since you are a more compact community, I hope that you can work and make this not too as dispersed and more tight on the method, because if you do it and you do it right, the numbers show that you can get 80–90% of the people corrected without the need for anything else other than just using the brace for 4 years. So thank you so much, and if there is any questions or concerns. There's no need to start the casting and the treatment the first day of life. And I think that is something very important. That everybody gets very tired, the parents and the pediatricians, and everybody's like, oh, we need to start. There's no need to start. You treat a 16 years old with 6 scars, you can treat a 2 days old with 6 scars. Our advice, and because of the problem with the brace, is to wait until the kid is about 4 or 5 kilos. Usually we start, in pounds, 7 or 8 pounds. The reason for that is because otherwise the foot is too small. And there are some kids that are born and they are 4 kilos already, but there are kids that are 2.5 or 3. And so we just tell the family, we have to wait until they are a little bit bigger. Otherwise, you do the casting, they correct, relatively easy with 4 or 5 casts, and then you go to the brace, and then the brace is too big. And then you have to keep casting and casting and casting. So just wait, explain to the family. You have to just spend time with the family and say, don't worry, mom and dad and grandma, because grandmas are always, kind of there in the background. And then just wait until the kids is a little bit bigger. And if you don't have the braces here that are small enough, because there are some companies that don't have small shoes, then you have to wait a little longer until the foot is big enough for the brace. The issue here is that if the brace is a problem the first week or 2, when the parents start using the brace and the kid cries and they get ulcers, and it's going to be a nightmare for that family to use it for 4 years, because they just hate that thing from day one. So transition from casting to bracing has to be really smooth, and it has to be perfect. So that way the bracing becomes a normal routine for them. And I think this is a critical, very, very critical step in the method, because there's no question. I mean, you know, how many have kids here? Just raise your hand. Pretty much everybody. Can you imagine to put in your kids for 4 years the brace every night in one of your kids? I mean, I have 2 kids. If I think back on my kids when they were kids, and I had to put the brace every night for 4 years, it would have been a very difficult thing for me. I mean, it's very difficult for the family, but there's no other way around. So you have to work with the bracing, and I think this is a very good question, because you see that often. And when they hate the brace the first week, then it's really hard. It won't work.
It's a follow to that problem, because there is one issue which I have been able to solve, and I'm doing the Ponseti for 15 years. I don't know how you manage to keep them in a brace at night until the age of 4. Tell me the secret. At my population, at the age of 2, it's almost impossible afterwards to keep them in a brace. How do you do that?
Well, I think, and we were talking about that with John last night. My population specifically in Iowa, our population is a little bit different, because 50% of the patients come from other states, and they come through the internet because they have problems in other places. So there are people that are very motivated. But the other 50% are people from Iowa. The key is a psychology issue. And I can tell you 2 things. Number one, you as a doctor have to understand, and you have to really understand that up to 4, it has to be happening. If you don't believe that, then you are not going to push that into the families. And I think that is 80% of getting there. It's much easier to blame the families that they don't use the brace than to take the work that takes to convince the families to use it. And it requires a lot of talking and a lot of convincing. And so that's number one. So if you don't believe that it has to be until 4, and if you don't believe that doing surgery for clubfoot is not the best thing for the patient, then then they are going to feel that, and the families are going to start lowering the standards. And the second thing is that you have to have a good brace. And a good brace means comfortable shoes. And not all the braces are made equal. And there are braces that are comfortable, and there are braces that are not comfortable. And so there's so much that the family can take. So you need to figure out what brace is the one that it works the best, that is more comfortable, and that's the one that you have to recommend to the families, because that makes a huge amount of difference. And then the third part is, you have to talk to the families, and you start from day one, and you have to convince them, and you have to make them partners. I see so often that, people start doing the casting, and the family sitting in the corner. You do the casting with your nurse or something, and then you don't integrate the families into the treatment, and they are your partners. And I think that that's something that requires a lot of work of talking. And if you don't do that, it won't work. I can tell you that. And it has to be the doctor. The nurse is not, it doesn't have from the psychology as higher level as the doctor. The nurse says, oh, you have to use it, but then it's like, the nurse. But if the doctor says it and you work with them, then you can get more patients to get to 4. But it's hard work.